I just want to take a moment to introduce our two speakers, who will then be joined by our moderator. We have Nathan Johnson with us, who is the Chief Health Policy Officer with the HCA, and MaryAnne Lindeblad, who many of you know, is Director of Medicaid. And these two folks here are the drivers of the Medicaid integration work that's being done, and they're going to spend about 20 minutes or so sharing with you in their presentation, and then we'll be joined by Kristen West from the Empire Health Foundation for a Q&A after that. So save your questions if you have them, and Kristen will help moderate that panel. So I will turn this over. You guys have your mics? You're good?
Check it.
Check. All right. Enjoy. Thank you.
Thank you so much for that introduction. And we just, I think, very much appreciate being with all of you here today to talk through some things in the arena of Healthier Washington, specifically that apply to the Medicaid program. There's quite a bit going on, and in 20 minutes, we're not going to get to all of it, so I hope you'll forgive us that. But we want to spend the balance of the time as much as possible today interacting with you, your questions, comments for us. We are at a fairly critical phase in Medicaid transformation work in this state with the submission of a Medicaid waiver and now negotiating process that's heating up. So we really benefit from hearing from you, and again, greatly appreciate the opportunity to participate in another State of Reform conference. So thank you so much for having us here. So to set a frame for this discussion and Medicaid transformation in general, I think it's helpful to talk about this concept we call Healthier Washington. So this is the umbrella term, this is the frame, this is the brand of health transformation work that actually started 2.5 years ago with an innovation planning process. It resulted ultimately in a 5-year healthcare innovation plan. Following that, governor request legislation was passed on a bipartisan basis in 2014. And now, furthering the work of Healthier Washington, we've received a 4-year, $65 million grant from the Center for Medicare and Medicaid Innovation, and are now working on a significant request from our federal partners through the Medicaid waiver of up to $3 billion of additional investment in the work of Healthier Washington. Sustainability has been a theme in some of the conversations I've been privileged to participate in already this morning. And this Medicaid transformation discussion is much about sustaining the Medicaid program that has changed dramatically, and MaryAnne's going to talk a bit more to that. But the frame that applies to both Medicaid and the work across payers and in partnership with our federal government, for us follows 3 very specific aims, and I'll just cover those briefly before we go further. The first aim that we have under Healthier Washington is building healthier communities through a collaborative regional approach. This actually builds on decades of work in this state and critical leadership in various regions, including right here in this region with the work of Empire Health and Better Health Together in particular. It includes the work of the Whatcom Health Alliance in the North Sound region of the state and an organization, the Choice Regional Network, which predates everything known today as Accountable Communities of Health as we're moving forward. But importantly, what I think we recognize is health transformation is not sustainable unless it's being locally led, and unless the very difficult and crucial conversations that are necessary to sustain health reform and health transformation are happening at that local level. And so we'll say a bit more about that, especially how it figures into Medicaid transformation. The second critical piece is ensuring healthcare focuses on the whole person. Our health delivery system has grown up much more closely tied to the potential grant fund source or to the Medicaid fund source or the Medicare fund source, which themselves are fragmented, and has done a lot less in past, aligning to the needs of people that don't have needs that separate out at the neck up and the neck down in terms of especially physical and behavioral health. So one of the very, very crucial elements of Healthier Washington is better integrating our delivery system really at 3 levels: how we administer services, how we finance them, and ultimately how they're delivered. And while there's a particular Medicaid lens to this that MaryAnne will be speaking to in a second, this work does span delivery systems, payers, incorporates Medicare and commercial payers as well. And finally, Again, already heard a lot about this today, but improving how we pay for services. The old widget-based form of payment is what results in much of the fragmentation we see. We have to make huge inroads if we're to sustain the healthcare system that's been built as of today. Our goal is to have 80% of all state purchasing, which includes Medicaid and public employee benefits, in value-based modes of payment by the time we reach 2019. So with that introduction, I'm going to pass the mic off here to MaryAnne, who's going to walk us through a little bit.
Hey, thank you, Nathan. And again, what a great opportunity to be with you all today. And I want to talk a little bit about one of our first strategies, and Nathan touched on it, but this whole notion of whole person care. And those of you that are familiar with the Medicaid delivery system, you know that we have this very bifurcated system in terms of how we deliver mental health and substance abuse services to our enrollees. And we also know that through some national studies that folks with significant mental health issues die 25 years sooner than they would have otherwise if they didn't have a mental health condition. And they're dying not because of their mental health. They're dying because they have untreated hypertension, untreated diabetes. They're not getting the physical health care that they both need and deserve. So from a directional perspective, the state is moving into a new way of providing behavioral health services, and that's through a fully integrated delivery system. And through some legislation that passed in 2014, Senate Bill 6312, we have a direction of by 2020, physical health and behavioral health services must be provided through fully integrated managed care health systems. So we're moving in that direction, and as part of that legislation, we have this opportunity to do what's called an early adopter. So bring this online long before 2020. And we're doing some great work down in Southwest Washington, which there is a session actually this afternoon. I'll make a plug for that if you're interested in that, to hear more about what's happening down there. But to create fully integrated services through managed care companies, and that we will be selecting through an RFP process. And those things are starting right now so that we'll know who those plans are by the end of this year for a start date of April of 2016. And while that activity is going down in the Southwest Washington area, there's other work that's happening across other what you know today as RSNs, moving to what will be called BHOs or behavioral health organizations, where we will be integrating at least the substance abuse and the mental health services through a behavioral health organization, for the most part county-led. So that work is going on. We see this as being so integral to the changes that we were making in terms of how healthcare is delivered in this state and through this integrated approach. Then Nathan, I think, is going to talk a little bit about our value-based purchasing strategies that we will be moving ahead with.
Sure,
We're going to do a little tag teaming
missed my
here,
cue. I
so you don't have to
apologize.
listen to one of us for.
So today, the state has over 2.1 million beneficiaries that it purchases health care for, 1.8 or thereabouts with the Medicaid program, and another 350,000 public employees. That includes some local jurisdictions that receive their benefits through the Public Employee Benefits Program. With that comes about roughly $10 billion of expenditures every year. A significant component of the state budget is, of course, dedicated to healthcare services. And this, of course, does not include major components of the long-term care and behavioral health delivery system that are funded in other agency budgets. Bottom line, when you're responsible for a third of the non-Medicare population in the state, as we are, that has a significant mandate attached to it. It's a mandate that also builds on the policy direction the legislature has already established in, for instance, House Bill 2572, where they directed the state agencies to get serious about value-based purchasing and bring value-based purchasing into state programs. So that is a lot of work that we're doing and is underway now. Chiefly through the Medicaid lens, we rely very heavily on managed care organizations. Over 90% of our full benefit eligible population are served through health plans in Medicaid. There's usually in most of the populated areas of the state at least 5 plans competing for business. And that type of competition in the Medicaid frame is going to continue, even as we talk about some of the other transformation activities moving forward. But specifically, what we're testing under the opportunity afforded to us through the State Innovation Model Grant is some new payment methodologies with a critical component of our Medicaid delivery system. Over 40% of primary care is delivered in federally qualified health centers and rural health clinics throughout the state. As folks in this room may know, they're afforded through both federal and state law special cost-based reimbursement that is supposed to cover the full breadth of their costs for serving highly vulnerable and needy populations. But that payment also very much constricts their ability to innovate and gets them very focused on face-to-face encounters. So we're working very closely with our clinic associations and clinic leaders on bringing a new payment methodology up as soon as in 2016 to test what can happen when the state and federal government provide additional flexibility and innovation opportunity to the delivery system, in this case, one that impacts over 40% of our beneficiaries. Another key component of the Medicaid delivery system, especially in rural areas of the state, are critical access hospitals, which too have their own unique federal designation, which is both a blessing because it has retained some critical supports and services within communities that might not otherwise have them. It has also, again, hampered health delivery system innovation, given the constraints of the particular reimbursement approaches and the requirements on a hospital entity for that designation. So here too, we are working with some pioneer leaders among critical access hospitals of coming up with a new payment and delivery system approach. And this work is being led very jointly between the Healthcare Authority and the State Hospital Association, as well as some specific critical access hospitals that have expressed their willingness to engage with us.
So as one of the other strategies, it really is around these clinical and community linkages and this notion about really all healthcare is local and bringing local decision making with healthcare. We talk a lot about the 80-20 proposition and looking at, 80% of health is driven by factors that are outside the healthcare system. So when you think about that, it really is about what happens at the local level. How do we provide services at the local level, and how do we address the social determinants of health? And that's such a critical factor in terms of moving forward. And a significant part of our innovation grant is around standing up these accountable communities of health across the state. And I think many of you were probably in that very full session earlier today that talked about the ACHs and where they're headed. And just the work that we are doing with the ACHs in terms of bringing a number of players, community players, to the table to really talk about how to deliver services locally, how to choose the kind of priorities that are important at the local level, and addressing the health needs of those in the communities where folks live, and not so much the state dictating that, but happening at the local level. So you'll hear a little more about that when we talk about the waiver, but I think a really important component of the work we're doing is around these clinical and community linkages. So I'm going to talk a little bit about a very good story. But my first news that I'd like to share, if you haven't seen it, the uninsured rate in the state of Washington since the implementation of the Affordable Care Act has dropped from 16.8% to 6.7%. And that is a big shout out for our state. Absolutely. And it wouldn't have happened without the bipartisan support that we had to move forward with this. But when you see this significant growth in Medicaid, I mean, it is much more than we expected it to be. We were at what our 2018 projections by the end of 2014, and we keep growing. And as of September of this year, over 560,000 new adults. So those would be people that otherwise would not have been eligible. And they're different. Their demographics are different. When we look at the newly eligible, we're certainly seeing a higher percentage of folks with mental health diagnoses, with substance abuse diagnoses, more adults. While they may have lower hospitalization rates, they're coming in and they're staying longer, which certainly is indicative of coming in with a greater acuity, unmet service needs, and so it is a different population. I think the other important thing is, Medicaid traditionally has been a program where the greater proportion of individuals on Medicaid were children, and now that's switched, more adults than children. And in fact, we're insuring about 50% of the kids in our state now. We still pay for over 50% of the deliveries. So it's just the whole picture of Medicaid, who they are, and the demographics, while changing, Medicaid is becoming much more and more a critical part of the healthcare landscape in this state, when 1.8 million lives are now insured by Medicaid. And so then we sort of top this off with, I think, what you might hear of as the silver tsunami. So the age wave, what's happening. And if you look at that blue line is actually the growth between 2010 and 2060. So we're talking a long way out, but that's the 85 plus population. So that's what the growing population, and how are we going to take care of that population? How are we going to meet their needs? Because you see that population between, that are under 65 is certainly not growing at the same rate. The other thing I think that's important to note with this population is some really different in terms of what their healthcare needs are. So in the next, between now and 2035, so in 20 years, the number of people 75 or older will have grown by 150%. Significantly more people with Alzheimer's and other kinds of dementia. And what are the ways to care for that population, and how do we care and keep people in their homes that have significant health issues like Alzheimer's? I think the other thing that is really important to note, the number of us, as we reach 65 and over, if we live that long, we're likely, over 70%, likely to have a long-term service and support need. So we're going to be going into the long-term care delivery system in some way, whether we're maintained in our own home through home health aides, or whether we're living in a nursing home or an adult family home or some other community placement. And it's a significant expenditure to the state. Right now, $3.4 billion, and that's over 6% of the current general state funds. So it's a significant amount of money that we're spending for this population. And so when you see this really is the perfect storm. And what are the things that we're going to do to try to address sort of the buildup of what the system needs? And so I'm going to turn it back to Nathan to talk a little bit about where we're headed with our Medicaid waiver that you've heard off and on mentioned in several of the presentations earlier today.
Thanks, MaryAnne. And if you'll forgive me and being sensitive to time, I'm gonna go through these slides pretty quickly, and then we'll get to your questions on any topics we've covered, but I imagine in particular on the waiver. You've heard the burning platform. The Medicaid program's grown by 50%. We now serve over 55% of the program is serving adults. Many adults, by the way, that the Medicaid program has no history of serving before and is not necessarily prepared for from a delivery system perspective. You also have an age wave, a tsunami that's occurring of sorts, that despite our state having one of the best and rebalanced long-term care systems in the country, will not be able to sustain long-term care services for that age wave with doing the same old approach, especially in Medicaid. So with this burning platform, in November, discussions began between HCA leadership, DSHS leadership, and senior level CMS leadership on what it would look like to take those principles and priorities outlined under the innovation plan, put forth in legislation, and now captured in the State Innovation Models Grant. What if we took those and applied them even more broadly and universally to the Medicaid program? The chief purpose, though, of this waiver effort, and the reason the flexibility is so necessary, is we have no other mechanism of leveraging federal reinvestment of savings that have accrued both historically and will accrue to this state if we're successful on Medicaid transformation efforts going forward. There is no other mechanism for it. And if you look back over the last 20 years, having effectively rebalanced the long-term care system, having moved the vast majority of Medicaid beneficiaries into a more managed care environment where their care can be coordinated, we have saved. The state budget certainly has benefited a great deal from this, as has the federal budget. And to date, because our state has never previously operated its Medicaid program, broadly stated, under a waiver, we have had no ability to invest those federal savings. So the bottom line, the fundamental premise of this effort even as we talk about some of the goals and strategies related, is short of this tool, short of this negotiation process now underway with CMS resulting in a good outcome, even going forward, despite all of our best efforts, we'll only be creating savings on one side of the ledger. That's very problematic when for that 560,000 group that MaryAnne identified earlier, their funding is 100% federal funded today and will be only 10% state funded by the time we reach 2020. So the federal government, if we're successful, is going to benefit very handsomely, and we would like to see a component, a proportion of the savings that are achieved thanks to the hard work of folks in this room and the health transformation efforts ahead of us reinvested back in this state, back in the communities where health transformation can be sustained. There are 4 goals, basic goals to this waiver. The first may be an obvious statement, but we've expanded it a little bit maybe beyond the obvious. We want to reduce avoidable use of intensive services and settings. This includes normal Medicaid goals like reducing those acute care hospital stays that are unnecessary. Emergency room has been a topic of discussion today. This includes ongoing work to keep people in their home or community as appropriate for long-term care needs. This includes avoiding psychiatric admissions and readmissions, and especially is impactful to the new adult population, which had a lot of pent-up demand for behavioral health services. It includes other traditional long-term services and supports, if we can keep informal caregivers in the game, for instance, as well as jails, another institutional setting that doesn't often get talked about, but certainly greatly impacted by the Medicaid program. The second goal is to improve population health, specifically focusing here on some population-wide strategies necessary around diabetes, obesity, smoking, and upstream interventions with regard to mental illness and substance use. This cannot be strictly an acute care intervention approach under Medicaid transformation, and certainly that's not how we've tried to describe it in our discussions up until now. Third, we want to accelerate the transition to value-based payment. This aligns with the broader Healthier Washington goal. The opportunity under this waiver is to focus some of those efforts on the Medicaid delivery system components that have the biggest barriers to making this progress going forward. Great work already underway under the State Innovation Model Grant. We intend to build upon that through this waiver. And finally, pretty bottom line goal here, ensure that the growth of the Medicaid program on a per person basis stays at least 2 percentage points underneath the federal rate of growth. Again, this will be our argument to our federal partners that for that delta of savings created, we'd like to see a component of it reinvested back in the state, again to the tune in our initial request of $3 billion. Against those 4 goals as a backdrop, there are 3 particular initiatives. All of them deserve a much longer treatment than I'm going to give them, so I'll warn you that. Initiative 1, transformation through accountable communities of health. You heard this alluded to. The work around accountable communities of health actually began decades ago with some strong regional collaboratives. This state has a strong tradition. But we did a lot of learning during innovation planning of what their desired role could be and what a true partnership with the state could produce in the way of health transformation. So transformation through accountable communities of health builds on that work and is a significant investment. Initiative 2 is service options that delay or avoid the need for long-term services and for more intensive care, which we can do a deeper dive on if folks are interested. And targeted foundational supports, which brings about supportive housing and supported employment, not the actual housing costs, not the actual wages for employment, but the activities that Medicaid can pay for that keep people in housing and keep people stably employed out of jails, out of hospitals, out of psychiatric institutions. Here's our timeline. Importantly, the star has moved. We are now officially sort of in phase 3. We are also in the midst of a federal comment period, so folks have an additional opportunity to make comment directly to CMS on this waiver, and that link has been circulated. Here's a really great slide that talks about the integration of some initiatives, which I'm going to bypass for now. And finally, some contact information if you would like to stay informed on the progress of this work. Certainly a lot more to come. A lot more details must be hashed out. Part of that is going to be related in the negotiating process with CMS, which we intend to maintain a great deal of transparency around. But another component will actually be in the implementation phase. We've proposed an 8-month implementation phase for that purpose under the waiver, and really look forward to working with all of you to make it a success and get this through the gate. So thank you for your time, and now we're going to, I think, have Kristen come up.
Thank you, Nathan and MaryAnne. And thank you for speaking so quickly. so we get through the slides and have Kristen come up here. Kristen West with Empire, VP of Grant Programs at the Empire Health Foundation, will moderate with Nathan and MaryAnne. So thank you for joining us today and doing all the work with the HCA. So it was a good marrying of you guys up here. So thank you for that. Have your mic right there. Oh, yep. Got your mic.
Wow, well, this is exciting. I'm struck as I'm eating lunch and looking at your presentation what a challenge the two of you have to take something this profound of a change and complexity and communicate it generally to lots of different audiences. So I appreciate the level of attention that you've given to keeping everyone informed and in the loop. I feel like we are at a very historic point in healthcare, having worked in healthcare for a long time. And now that I'm at Empire Health Foundation, we take a very broad definition of health, that we dabble in our investments in terms of lots of different initiatives that look at graduation rates or childhood obesity rates and try to move the dial on those things. But until this waiver opportunity came along, it's been unclear to me how we, on a systemic level, make those kind of shifts in what we pay for and the outcomes that are associated with that. So I feel like a kid in a candy store when I hear you talk about the waiver. And I'm one of those people that actually likes the fact that there's a lot of opportunity to shape the details, because I think that's where we're going to learn and be agile about what actually works. So that leads me to my first question, which is, it almost sounds too good to be true. So too good to be true that the feds would let us do this, too good to be true that we might be able to achieve these outcomes on such a short time frame. So in your mind, on the continuum of slam dunk to long shot, where are you in your negotiations with CMS, and how are those negotiations going?
Want me to start? Okay. Well, I mean, it is a process, and it is a journey, I guess, than what I would say. And we have been very fortunate to be one of 3 states that were selected to do some work with the National Governors Association, and that's helped us, do some get some technical support and other things to be moving forward. But the reality is the hard part is just starting. We are going to be, starting to engage CMS more. We had to get through a couple of hoops first, and now that they've accepted our document, and now that we are at a place to start those negotiations after the 30-day comment period. So I don't think anything's a slam dunk by any stretch of the imagination. And I would hate to say, gee, I think it's 50-50 or 80-20 or whatever, but I do think we have an excellent chance of moving forward with this waiver. Certainly, as other states have moved forward with these kinds of waivers, the stakes have kind of ratcheted up. So it's every state is going to be a little harder to reach the goals and to achieve what CMS wants with these kinds of waivers and the kind of investment that CMS will make with states to get that return on investment. So while, again, I don't think it's a slam dunk, I think Washington has a very good chance. They like what we're doing here. They've been very interested and very intrigued with what we're doing. And the kinds of work we're doing with the ACHs and that accountability at the local level is not something that's being really replicated other places.
I'd concur, and I would say that this is the best chance the state has ever had to implement a global waiver for its Medicaid program and secure the type of federal reinvestment in its activities going forward. We've never been on the verge of something this significant, but as MaryAnne suggests, some caution is totally appropriate. We have a timeline that's fairly tight. We have a federal administration that will end one way or the other at the end of this next year. And so we have a very, very tight window in which to get this right, in which to have fairly complex negotiations. So it is a long road, and the difficult work is absolutely ahead of us. And that's why I think, in part or in whole, we want to engage as many people as possible in that effort, both so that CMS sees this emerging as consensus from a state, but as well to ensure that the details are as soundly and tightly wrapped as possible as we get closer and closer to approval of this waiver. Our target is to have this waiver approved by spring of next year. And that'd be one of the quickest waiver negotiations, at least of this nature, that CMS has ever engaged in. We have a bit of a running start, but we know it's a push, and we'll ultimately need the help of folks in this room to pull it off.
And to make it happen this quickly, that would imply that the governor's behind this and the legislature's behind this. Are they working as hard as you to make this happen?
Sure. What I'll say first is the opportunity MaryAnne referenced was exclusively through the governor with the National Governors Association and technical assistance, which has actually brought us the national experts, in fact, experts who used to approve these types of waivers for the federal administration to work individually with the 3 states, including Washington, on the development of our waiver. So that is part and parcel of the governor's leadership that's brought us that. In terms of the legislature, what the legislature has done, and I think very boldly and has distinguished itself from other states around the country, is it has set the boldest and very clear policy direction for the Medicaid program. There aren't too many states trying to pull off integration of the magnitude and of the nature that this legislature has instructed, for example. And CMS sees that, and I think has a very strong sense of the legislative leadership that historically in this state has led on healthcare and continues to with the Medicaid program and the transformation efforts ahead of us. So I think we have a really strong team, and it does go across the branches of government for certain.
So while this is a Medicaid waiver, what impacts do you see this having on the commercial market? And in particular, what do you see changing for health plans?
Well, I think certainly when you think about, again, 1.8 million lives in Medicaid, and we've now become the largest purchaser of healthcare for folks under age 65 and under. So when you think about that, hugely significant in terms of the kind of work we do and how that will transform and transcend the delivery system, and I think into the commercial market space. And the kind of work that we're doing now on performance measures and other activities, the coordination that we're doing with state employees. The Healthcare Authority, when it I would say reformed about 4 years ago. It was really bringing in the state purchasing into one entity. So you are purchasing in both the commercial market, state employees, and the Medicaid space. And it gives us this opportunity to start to leverage that purchasing and push it out into the commercial space. And the kind of work we do, particularly as you think about behavioral health and the integration side and how that can impact how the commercial marketplace can operate, setting common performance measures at the community level. I think all of those will have an influence on how healthcare is delivered in our state and have a more common platform to deliver services.
And I would just add that there are actually very few providers in the Medicaid delivery system that see exclusively Medicaid beneficiaries. And so when we talk about the types of delivery system transformation investments envisioned under Initiative 1, which we did give short shrift to, but one of them is integrated care models. The legislature has set this policy direction around integration, but this provides us a tool to make some critical investments in delivery system capabilities at the primary care, behavioral health, and broader delivery system level to actually deliver on the promise of integrated care, which does go beyond just how we purchase the service, but also to how it's delivered. There are major infrastructure gaps that require very significant investment to pull that off. That's one opportunity. Another that was referenced earlier in one of the panels today is community paramedicine, which some communities have already taken off with, but could be greatly emboldened, scaled, and spread even further as one of the example projects that are included in the waiver application. We've also mentioned things like nurse-family partnerships and other oral health interventions in the waiver application, just as examples at this stage of what is possible under the type of delivery system investments envisioned under Initiative 1. And a lot more to come on that. But I guess the point in saying those things is these type of interventions rarely apply exclusively to Medicaid beneficiaries, and the type of upfront investment potential we have will have direct and absolute implications across the delivery system if we do it right. But this also speaks to the import of local leadership, regional leadership, and ACH-led leadership as it's envisioned under the waiver to make sure we're not getting too siloed or even Medicaid-centric when it comes to delivery system reform discussions.
So one of the things that I learned today is that the federal government's looking for innovations in these waivers. They don't want to do the same thing over and over again. And it seems like one of the unique aspects of this waiver is the creation or use of accountable communities of health. There's also a lot of other acronyms in both the innovations plan and the waiver. So where did the idea for these ACHs come from? And what unique role do they play compared to ACOs or BHOs or MCOs?
I can start. I think when we think about it, we've had what I would call ACHs in our state. And Kristen, I think something to give you great credit for was choice. In Western Washington, in the 5-county area around Thurston County. But when you think about that, we have been a state that has innovated. So it's really leveraging off of work that we have a foundation, and it's not just choice, but in many parts of our state, we've built these. We didn't call them accountable communities of health, but there were partnerships at the local level to really think about how we coordinate, collaborate, and deliver care differently and better, and not be all about the delivery of health care, but really the delivery of health. And I think that's what's unique about the ACHs, and it's that 80-20 proposition that we think about where 80% of health is not really influenced by the healthcare delivery system. There are other factors that do that. And Washington State, I think, has been truly a leader in that kind of innovation. So to be able to build off of what we already have and have those ACHs and then partner with other types of organizations that are also reforming, and I'll put that in quotes at this time. So this is just, it's not a new concept. It's a concept that I think is built off the great work that we've done in our state over the last, probably 20 plus years, frankly.
I would just add one critical factor too. The biggest distinction I would think between an accountable community of health, which is built on a collective impact and really a mutual accountability model for the health of a defined population, in this case regions, as we've set them up here. That level of accountability and performance risk that's envisioned under the waiver for actually implementing the activities in that leadership component is very, very different than the risk that we ask behavioral health organizations and managed care organizations to bear, which is service risk and insurance risk. Other states have pursued Medicaid transformation and at times have confused those two things, and I think has hindered some of the efforts in other states. We've tried to be very clear that there can be local community accountability as well as insurance risk continue to be managed by managed care organizations, and that you need both of those to be very strong and very appropriately defined and very complementary of each other to succeed in the Medicaid world. So that is distinctive of the Washington State approach, that when you compare us to Oregon, a peer state that we often look to, or New York, a recent Medicaid waiver state, really does differentiate this approach from what CMS is used to seeing. And I'd like to think, gives CMS some hope and some promise that some of the, frankly, failed efforts or failed investments of prior years could be addressed very differently with the foundation this state is operating from. So that is the promise. And as you alluded to, CMS doesn't want waivers for the sake of dumping a bunch of money into a state because we think it's a good idea. They want us to be actually demonstrating something. We believe our application proposes something that would actually demonstrate something to our federal partners, but as well other states that are serious themselves about Medicaid transformation efforts. So that is the opportunity, and Accountable Communities of Health figure very uniquely as an organization with significant leadership around Initiative 1.
And it's my understanding that another thing that the feds want with this waiver is state match for the federal dollars. What are your thoughts about where that state funding will come from, and what have other states with waivers looked to for sources?
Yeah, federal dollars for Medicaid don't typically come without state match unless we're talking about the Medicaid expansion, which was a pretty good deal for states, including this one. But for purposes of the waiver, even though this is a very unique and shared investment approach that the federal government very much understands the intent here, they still need a methodology, a process, a point at which they can attach federal dollars to state or local match dollars. The process that states have used, not to add another acronym to today's discussion, is the Designated State Health Program, or DSHP for short. If you ever hear me say that, you'll know what I'm talking about now. But what DSHP's and Oregon's waiver relied very heavily on DSHP's. Basically what they do is they define an existing program. It has to be public in nature, operated at a state or local governmental level. And the program has to have a nexus to the Medicaid population. It doesn't have to be Medicaid services or state plan services, but there has to be a clear and documented nexus between that program offering, for instance, local supportive housing dollars or state supportive housing dollars, and the population it's serving, which now 1.8 million, the vast majority of whom, which there'd be an overlap in that particular case. You call that program and define it a designated state health program. If it's $20 million state investment or local investment, it draws down an additional $20 million of federal investment through the DSHP approach. The other mechanism used most recently in New York, a considerable portion of their waiver, is intergovernmental transfer, which basically, if a public entity, either a state or county or local government entity, and in this state, tribes have actually participated in the intergovernmental transfer program. Basically, they have to write a check of unencumbered dollars. And if an intergovernmental transfer program is approved, that check then is matched with federal dollars. I didn't intend necessarily to go into that level of nuance, but there's a lot of acronyms that fly around on match. I guess our bottom line is we're confident that with a mixture of both, and our preference is to rely as heavily on DSHPs as possible, but with a mixture of both, we believe we will be able to provide enough local match to draw down the federal match without any additional expenditure or additional revenue needs of any kind. So we are not asking for any new state appropriation. We're not asking for any new budget authority other than the budget authority necessary to expend additional federal dollars that would come through this waiver.
Sounds like there's a lot of conversations to be had on that front. Back to the accountable communities of health. I go back and forth myself on this particular issue. This is a gross oversimplification, but I'd be curious about your thoughts on when the innovations plan first came out and the ACHs were created and the regional priority process established. It felt like there was a lot of tolerance for regional variation in terms of activities. And with the Medicaid waiver and the need to hit statewide outcome goals in a pretty short period of time, that it's hard to imagine doing that with a bunch of different activities happening across the state that don't add up to hitting those metrics. So how much, in your mind, flexibility is there with these ACHs to define what they do regionally versus now the Medicaid waiver is driving everything?
Well, certainly, at least for the work that the ACHs are doing related to the waiver, there will be limited number of activities. We haven't defined whether that's 5, 10, whatever that number is, but the reality is CMS has been really clear, and they use the state of Texas as an example where they had over 1,000 different programs going on, and to try to track and measure and see outcomes, that they're not going to approve a waiver with 1,000 blooming flowers. We're going to have to be more limited in terms of what we do. We know there will be certain things that we will want that'll be designated at a state level, so that the state will want to have certain things like behavioral health integration. Certainly activities around that would be statewide. But we also know that there's local innovation happening, and we want to make sure we can encourage local innovation, but there will be a list of a number of projects that folks can pick from. So it isn't just anything throw the door open and you can have anything you want, but what would be a limited number of, and we haven't chosen what that number is yet, but again, it's not going to be a list of 1,000 different things, but things where we really think we can make a difference, and there will be things that will be common across the ACHs, but there will be things that will be unique to each ACH.
And this speaks to a fundamental tension in health transformation, I think, of wanting to get to some common statewide goals, wanting to have some common statewide accountability, but also recognizing that the needs of communities, the gaps that folks are trying to fill, the measures that are of most concern can at times vary. And so we want to provide, in the case of integration, very, very clear state policy direction and then funding to back it up. But in the case, for instance, of community paramedicine, that's perhaps an approach or a project, if it ends up on the menu of potential projects, that some regions would see great value for, at least under this waiver, and others would not see as much value for. And we want to, in that example, provide room for that discussion to be had at a regional level with the appropriate people around the table. And that is the role an accountable community of health can play. The other thing I should add is, in addition to not letting 1,000 flowers bloom, another thing we've hit on pretty directly in the waiver application itself is the idea that we will be relying on evidence-based interventions for the most part, or at least promising practices. So that is to say, activities undertaken either in this state or in other states that for whatever reason have not been scaled or spread but have some proof and evidence behind them. There are populations for which not a great deal of evidence exists, and there will be exceptions, of course, to this rule. But when we're building a 5-year demonstration that has to be budget neutral and has to pay for itself, whatever federal investment has to pay for itself over that 5 years, we have to rely on what the evidence suggests is the most likely to succeed in our various regions and then at a state level. And that is something we're incredibly committed to, and I know CMS is very committed to based on prior experiences they've had with other states.
And I think the only thing I would add to that too is the sustainability side. So it's one thing about the 5-year waiver period where there's the ability to use federal dollars, but when that ends, we've got to have, we have had to build a system for those projects that are successful that we can sustain them, because what we don't want is to put things in play and then at the end of 5 years they're not sustainable, the money's gone, and we can't continue them, and they've been meaningful things for communities. So that's going to be a really important aspect of this.
Great. Do we have time for questions from the audience? We do. Great. So I'll open it up to some questions from the audience. Up front here.
Thank you. Since we're sitting, I'll remain seated. I'm Chris McFall, Horizon Hospice. And when I hear you talk about Medicaid integration, the silver tsunami, the panel now is 55% adult. One of the inevitabilities of being human, unfortunately, is that at some point, better health is not a tenable option, right? We still have the option on the table of better care and affordable care. But my question is, are there any specific initiatives in place in order to help integrate end-of-life care, quality end-of-life care, into this big picture of, it's a small piece, but it's a huge impact cost-wise. Are there specific initiatives on the table or talked about in terms of reducing barriers to getting high-quality end-of-life care and maybe increasing the education and integration around understanding the end of life and those options that are available through palliative care and hospice care? Thank you.
I'll be honest and say that this end-of-life issues have not come up prolifically in the waiver discussions up until now. That is not to say that it is not an issue of great import for the Medicaid population, for that matter, dual eligibles, for which Medicaid is significantly responsible for. What I would say and offer is in the process that's immediately ahead of us and the design of projects, especially under Initiative 1, I think there is great opportunity for both regional and statewide level discussions. We've proposed in the waiver application a statewide work group specifically with the task of designing the menu of projects that are in fact evidence-based and then could be tried and tested either again at a local or statewide level. And I would invite that theme from the one that you just shared immediately into that discussion as it moves forward. I think it is incredibly relevant. I also think when we talk about integration, one service that gets left behind oftentimes is oral health, which is a very unfortunate way of the present Medicaid program being administered. It is a carve-out and it's treated like that. But end-of-life care, oral health, or other issues associated where there are clear defined approaches to addressing the need or the gap that exists, there's great opportunity in the process we're using over the next few months to insert that type of information and feedback. So I hope you'll take us up on that.
And I would also say outside of the waiver process, we've been having discussions about end-of-life care as it relates to another initiative that's undertaken by the Healthcare Authority in partnership with a number of individuals called the BRE Collaborative, which is another public-private partnership. And end-of-life care has been one of the areas that they've been studying and looking at in terms of how we can provide a better resources for individuals for both hospice and palliative care.
Great. So thank you very much for introducing us to this topic. It looks like our time is over.